Good morning, my name is Jon, and today I'm going to present our work on the analysis of the electronic health records of 3 different populations to study the prevalence and biases in the administration of drugs that are known to interact. As we all know, as we age, the risk of suffering from 2 or more chronic conditions at the same time increases. As a result, the same patient can suffer from several conditions, such as the one shown here. And to treat this disease, the patient will have to take several drugs, some of which will interact, meaning that the effect of the drugs might be altered when taken in combination. In this study, our objectives are to analyze the patterns of co-administration of drugs known to interact, looking for age, gender, and health system associated differences, and to evaluate later the amount of interactions that can be avoided. To this end, we have gathered electronic health records from Indianapolis in the US, Blumenau in Brazil, and Catalonia in Spain. As I said, the goal is to study drug-drug interactions, from now on DDI. What can be defined as the effect that one drug exerts on another one at the pharmacodynamic or pharmacokinetic level. This information has been extracted from DrugBank, which provides pairs of interacting drugs and a description of the interaction, such as acetaminophen increasing the metabolism of warfarin. Then we have extracted the severity of interactions from drugs.com, classifying interactions as major, moderate, and minor. Finally, taking advantage of the anatomic therapeutic chemical classification, we have identified those drugs that belong to the same chemical subgroup and that can be generally used to treat the same conditions, which will be used to look for alternatives to avoid DDIs. Drug administration information comes from drug prescriptions and billing information, and we have identified those drugs that are co-administered, meaning that the patients will be taking both of them during the same period. Doing so, we have observed that more than 70% of the population takes at least once a drug co-administration, being higher the risk for women. Interestingly, when we focus on the set of drugs known to interact, we found that the risk of DDI co-administration is even larger for women. Since we know that the risk of multimorbidities increases with aging, we evaluated then how the risk of co-administration changes also with aging, finding that in 3 populations, there is a characteristic drop at the age of 10 to 14 years old, and that afterwards increases, being first higher the risk in Indianapolis and later in Catalonia. Focus on DDIs, the risk also increases. But interestingly, even if the larger amount of administrations are observed in Indianapolis and Catalonia, Blumenau is the one presenting the largest risk of DDIs. To evaluate whether the increase in the risk of DDIs with aging is due to the larger co-administration rates, we built a null model suffering drug labels, finding that there is a first period during youth where the risk of giving interacting drugs is lower than the expected by chance, and from that moment on, the risk is higher. In other words, the increased risk of DDIs with aging cannot be solely explained by higher polypharmacy rates in the elderly. Then we have analyzed separately men and women, where men are denoted in blue and women in red, and we have found that women are at a higher risk of co-administration in almost all of the age ranges, being significantly larger the difference during youth in the 3 populations. Interestingly, in the case of DDIs, some differences can be found between populations. Even if the risk is still larger for women in Blumenau and Indianapolis, the largest difference is found in the elderly in the case of Blumenau and still during youth in Catalonia. The greatest difference appears when we focus on Indianapolis, where we observe that men and not women are at a higher risk of DDIs in the age between 50 and 89 years old. To understand better the differences in the gender-associated risk of DDIs, we looked for differences based on the severity of the interactions, finding that the tendencies are dominated by moderate severity interactions, which are taken by 80% of the population. Surprisingly, when we focus on the set of major DDIs, which are taken by 40% of the population and are those where the risk outweighs the benefit, we observe that both in Indianapolis and Catalonia, men over 50 are at a higher risk of major DDIs. To evaluate whether the difference between Catalonia and Indianapolis can be driven by the over-administration of a specific drug, we focus on omeprazole, that is the most frequently administered drug in Catalonia and is frequently co-administered with benzodiazepine derivatives such as diazepam and alprazolam. Indeed, we observe that in Catalonia, there is a significantly higher risk of giving benzodiazepine derivatives in combination with omeprazole rather than the other proton pump inhibitors with less known interactions. In contrast, in Indianapolis, any other proton pump inhibitor is used before omeprazole in combination with these drugs. Interestingly, substituting the use of omeprazole for other proton pump inhibitors with fewer known interactions, we observe that men over their 60s are at a higher risk of DDIs in Catalonia, which means that the over-administration of omeprazole in Catalonia can by itself explain the difference observed between both populations. In fact, the use of alternative proton pump inhibitors could reduce the number of patients taking DDIs by 21% in Catalonia and Blumenau and by only 2% in Indianapolis. Finally, we looked for the drug pairs with the greatest differences between genders in the different age ranges, finding that in Catalonia, the combination of ethinylestradiol, a contraceptive, and amoxicillin is responsible for the greatest differences in the DDIs in young people. As mentioned, there is a significantly higher risk of administration of omeprazole and benzodiazepine derivatives in women, being larger the difference in the elderly. In the same direction, the risk of administering hyaluronic acid used to treat osteoporosis, together with painkillers such as naproxen and ibuprofen, is larger in women, correlating with the huge differences between genders in the diagnosis of osteoporosis. On the other hand, the risk of combining drugs used to treat diabetes and acetylsalicylic acid is higher in men, what correlates again with the differences in the incidence of diabetes. This difference is also observed in Indianapolis. This means that the differences between genders in co-administration of DDIs can be driven by differences in the prevalence of the diseases and their comorbidities. So to summarize, in this study, we have observed that the risk of co-administration of DDIs increases with aging, and that the increase cannot be solely explained by higher polypharmacy rates, pointing to comorbidity relationships as potential drivers of such increase. In general, women are at a higher risk of DDI, excepting men over their 50s in Indianapolis, and such differences can be driven by the difference in the prevalence of certain diseases and that differences in treatment policies between countries, such as the overuse of omeprazole in Catalonia, what can promote huge differences between populations. Finally, I would like to thank all the co-authors of the work and all the members of the computational biology group led by Professor Alfonso Valencia.